Namaskar. I am Dr. Atul Gupta, diabetologist and internal medicine specialist from Delhi, Lawrence Road. Today, I will be talking something about the latest updated hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% people in the age group 40 to 69. A raised blood pressure is amongst the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has gone up over the last 30 years. Presently, it is 38% in males and 32% in women, from earlier 29% and 28% respectively. This is as per the WHO. Despite that, nearly half of the people, or 51% of men and 41% of females with hypertension, they were unaware of the condition that they are having a high blood pressure. Additionally, over 62% of the males and more than 53% of the females who are living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension, that is ISH, has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms, it attempts to address the issue that in resource poor settings. While the optimal care, it refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The AHA, that is American Heart Association, and ACC, they have also released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with a low atherosclerotic cardiovascular risk. Among the low risk adults, that is no ACVSG or 10-year cardiovascular risk of less than 10%, with stage 1 hypertension, that is blood pressure, systolic 130 to 139 and diastolic 80 to 89 millimeters of mercury. The management starts with a non-pharmacological therapy. If the BP remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. And also acute respiratory distress syndrome, that is ARDS. This is a potentially fatal condition involving lung damage, and experts often associated it with a severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol, it can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. The fourth update would be that lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury. It substantially reduces the cardiovascular adverse events in the STEP randomized trial, thereby affirming the sprint findings for an older Chinese population. Among some 8,500 patients with age group 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Findings from now a second major trial supporting a lower target would unite the guidelines, which even among the US professional societies ranged from threshold of 130 to 150. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on the office BP measurements, but also on and out of door or out of office measurements, such as ABPM or home blood pressure monitoring. 24 hours and nighttime BP measurements were associated with a greater risk of mortality and a composite of cardiovascular outcomes. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 30 millimeters increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. The sixth update would be the most patients with hypertension, they require a lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs, considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor ARB plus calcium channel blocker or diuretic. Since early 2018, products containing valsartan they have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitroso-dimethylamine, that is NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from a Zhejiang, that is a manufacturing site where the highest levels of contaminants were found, every day for 6 years in the highest doses, it could result in 22 additional liver cancers over the lifetime of these patients. Thus, the presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. So, the valsartan recall accompanied by a significant increase in the rate of emergency department visits of almost plus 6%. The highest study, it represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The Hygia chronotherapy trial tested whether nighttime therapy, in comparison to the usual upon awakening hypertension therapy, it exerts a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1752 participants experienced the primary CV outcomes, and ambulatory BP measurements was performed for 48 hours to collect data on how the BP differed during the sleep. The relative risk reduction for CV events was significantly improved for nighttime measurement treatment when compared with the awakening treatment. So these were the latest updates in the management of hypertension. Thank you. Dhanyavad.